Good afternoon. I'd like to thank the program committee for inviting me. Um, and this meeting promises to be a very successful one and a great start. So I'm going to talk about the shaggy aorta and how to manage that. I have no disclosures. The shaggy aorta is a precarious type of condition with a very aggressive atherosclerosis involving the aorta, and it's very common to have ulceration, thrombus formation, and occasional calcification, what is called as coral reef atherosclerosis. Can infect any part of the ascending aorta, descending aorta, or the abdominal aorta. And obviously, there's a propensity for increased risk of spontaneous embolization or provoked thromboembolism during endovascular and open intervention. Well, we often encounter aortic thrombus or a shaggy aorta, which is asymptomatic on imaging, whether it's CTA or duplex or MRI. It can induce spontaneous thromboembolism with a blue toe syndrome and visceral embolism. And again, as I said, it could provoke thromboembolism by endovascular or surgical intervention. The fact of the matter is there is no level 1 evidence that guides therapy for a shaggy aorta. And what I'm going to present to you is really retrospective data from large volume centers on endovascular and open treatment of the shaggy aorta. I think the first thing that the group at Mayo Clinic did was to look at grading of the shaggy aorta. And they found that volumetric analysis is pretty much similar to qualitative analysis, which looks at how many segments are involved, the thrombus type, thickness, area, and circumference. And by that, they score the shaggy aorta. Well, how does this relate to complications? Well, clearly, if you have mild versus moderate or severe shaggy aorta, the clinical outcomes vary significantly. And it's really presented with solid organ infarction in 24% of cases and acute kidney injury in 21% of cases. There's a significant association between a higher aortic wall thrombus indices and time to resume enteral diet and decline in renal function. Interestingly enough, stroke and spinal cord ischemia were not associated with this, perhaps because the spinal arteries were covered with thrombus. A second paper from the same group looked at progressive renal dysfunction based on the shaggy aorta index and found that there was a strong correlation with renal dysfunction long-term as the index increased. This paper was published by the Japanese, Takuoki, and they used a different scoring system. And moving up, I should mention that the Mayo group looked at type 4 and pararenal aneurysms. In this particular paper, the thoracic aorta and TVARs were looked at, and the thrombus index or the shaggy aorta index was greatest in the descending thoracic aorta, and that correlated very much with the risk of stroke. 80% of patients who had embolic phenomena had a stroke, with 10% acute renal failure and 10% distal embolization. So it is indeed very precarious to intervene on these patients. Now, what about open surgery? This is from Germano Melisano's group. And again, they compared the shaggy aorta versus the non-shaggy aorta for thoracoabdominal aneurysms. They used distal aortic clamping of the right renal, SMA, and celiac trunk prior to proximal aortic clamping and aortotomy with catheter occlusion of the intercostal arteries. This is a long table, but the 30-day mortality was about 4 times greater in the shaggy aortic group. Renal failure, the same. There was also a stroke was not different, neither was paraplegia, and there was bowel infarctions greater than in the shaggy aortic group. So again, it shows you that as the aorta is involved with this process, there's a much higher risk of significant complications and increased mortality. Their conclusion was that obviously the shaggy aorta treated with open surgical repair had worse post-operative outcomes, but the presence of the shaggy aorta itself is a risk factor, whereas the grade of shagginess did not seem to impact on post-operative outcomes. This is a rather interesting study from Japan, which looks at patients who have dissection, patients who have non-shaggy aorta and shaggy aorta, and clearly the operative mortality is about 33% in the shaggy group, and spinal cord injury almost the same compared to the dissection on the non-shaggy group. So what do we do about this asymptomatic shaggy aorta? There is no level 1 evidence. All I can say is first, do no harm, avoid intervention, uncomplicated shaggy aortas. Look at the lipid profile, thrombophilia workup, use antiplatelet agents, statins, anticoagulation to hopefully minimize any thromboembolism. There are some tips and tricks to potentially reduce thromboembolism if you have to intervene. Aortic cross-clamping in a non-shaggy segment, endarterectomy and graft replacement, if you're not careful, can be disastrous. An old technique, I think, which is very valuable, and especially in patients with a blue toe syndrome, is an axillary femoral bypass and ligation of the external iliac arteries. And during an EVAR, loading with Plavix statins, temporary femoral artery clamping, keeping the AST up, and completion arteriography is important. There are no currently filters for the aortic segment, but some people have deployed partially a wall stent distal to the stent graft to minimize embolization. These are two papers that show some innovative techniques. One of them is to cover a posterior wall thrombus in the shaggy aorta. This has to be really localized, and basically it's a staged procedure with a cuff placed initially, followed by the fenestrated or branched stent graft. And then this is a clampless, sutureless conduit which avoids clamping of the aorta by just suturing a graft as a conduit to the adventitia and outer media, followed by puncturing the aorta and putting in a stent across the aortic wall. So that minimizes suturing or clamping the aorta. So in summary and conclusion, do no harm, intervene only when absolutely necessary. Endovascular and open interventions are associated with significant increase in atheroembolic, cerebral, renal, visceral, and lower extremity events, and increased mortality. Stroke is more prevalent with TEVAR, and then ligation and using of the femoral arteries when you're doing an AX by FEM for a shaggy infrarenal aorta, and the adjunctive techniques that I just showed you might help you in reducing thromboembolic complications. Thank you.